Okay, cool. So let us go into the thrombocytopenia part. So which we have been discussing, and we left because of some reason. So the thrombocytopenia is basically an immune thrombocytopenic purpura, and which means it's a type of a secondary ATP which we have been discussing. It's not a primary ATP which is idiopathic, and this is due to antiplatelet antibodies. Of course, the reason for development of this thrombocytopenia is due to the presence of certain group of antibodies, which we call it as something called as anti-platelet antibodies. Fine. All right. People with SLE can also develop a sort of an Evans syndrome like of picture. What do you mean by Evans syndrome? Evans syndrome means the patient has hemolytic anemia, along with it, the patient has immune thrombocytopenic purpura, that is immune thrombocytopenia, that is ITP. Then we can also call that as something called as Evans syndrome. But remember, it is to be idiopathic. In order to call it as Evans syndrome, it has to be idiopathic. A patient who is having an SLE, having an hemolytic anemia, and having an ITP will not be called as the ones who are going to have Evans syndrome. Evans syndrome means it has to be idiopathic hemolytic anemia and immune thrombocytopenic purpura. So that is called as Evans syndrome. Finally, okay, let us leave off the blood picture for now. And next, moving on to the lupus nephritis part. That's really, really important. Kidney involvement. So kidney involvement in SLE is what we refer to as something called a lupus nephritis. And remember, patients with SLE can also develop something called a TTP. I didn't talk about that. It could be considered as a blood manifestation, or it could be considered as a neurological manifestation, or it could be considered as a renal manifestation. Nevertheless, patients with SLE can develop TTP also. That is due to antibodies against ADAMTS13. They also generate this ADAMTS13 antibodies. So there will be reduced activity of ADAMTS13, which is a protease that is very important to cleave the multimers of von Willebrand factor into monomers, which we'll be studying later on. So because they form antibodies against this ADAMTS13 molecule, they can develop something called a thrombotic thrombocytopenic purpura as well. And next, moving on to the lupus nephritis, we know we have different classes of lupus nephritis. So you have 6 different classes, we know that. So let us see in a nutshell, because there are separate textbooks for lupus nephritis. But anyways, let us see everything as a whole in a summary. So we have class 1, class 2, class 3, class 4, class 5, and class 6 lupus nephritis. You have 6 classes of lupus nephritis. The first class we call it as either a focal mesangial, that's the old name, and the new name for that is minimal mesangial. First, let us see the names. The first one is called the focal mesangial, or the new name, the current name is the minimal mesangial. And the class 2 we call it as mesangioproliferative or mesangial proliferative. That is class 2. And class 3 we call it as a focal proliferative type. The old name for class 2 is also referred to as diffuse mesangial. The class 1 was initially called as focal mesangial. Class 2, the old name was diffuse mesangial, but the current name is mesangial proliferative. Class 3 is focal proliferative, and class 4 is diffuse proliferative lupus. And class 5 is membranous type of lupus, membranous nephropathy, membranous type of lupus, and class 6 is advanced sclerosing type of lupus. These are 6 classes of lupus, and of course, you know, the most common class of lupus nephritis is going to be the class 4 lupus nephritis, and this is the most common form of lupus nephritis, and this is the one that has the worst prognosis also. And this is also the lupus that has the best response to immunosuppression. This is also the lupus that has the best response to immunosuppression, and this is also the lupus that has the worst prognosis overall. And it's the most common type of lupus nephritis as well, class 4, diffuse proliferative, or otherwise referred to as diffuse lupus nephritis. So now we saw the names, nomenclature. Next, we need to go for the second. What will be the clinical presentation? Clinically, how they will present. So class 1 will present completely asymptomatically, which means only if you do some biopsy, you will be able to find it. Otherwise, you will not be able to find out. Class 1, class 2 also will be completely asymptomatic. As class 3 and class 4 is concerned, class 3 and class 4 will present with a nephritic syndrome, In the sense they are going to present with acute glomerulonephritis most often. That's how they will present. In the sense like there will be a characteristic triad. That's how they will present. They can present with hematuria, proteinuria, and they'll present with AKI, acute kidney injury. So this is the classic triad of nephrotic syndrome, plus or minus hypertension. They can have hypertension as well. Classic glomerulonephritis triad. In that we know hematuria, if it's of glomerular origin, the one important feature of this hematuria will be they will be having RBC CAS. I'll tell you about the importance of RBC CAS in nephrology. RBC CAS are really, really important, and that's a quintessential sign of this hematuria. That is the blood that is coming out from the glomerulus. Blood coming out in the urine is from glomerulus. That is of glomerular origin. And to tell significant proteinuria, there should be at least more than 500 milligram per day, or I can tell it as more than 0.5 grams per day. If it is more than that, then it becomes significant. That's how the glomerular proteinuria presents. So this is going to be the characteristic triad as far as the class 3 and class 4, the nephrotic syndrome, glomerulonephritis is concerned. Class 5, we know they are going to present with membranous nephropathy. Membranous nephropathy means they will be presenting with a nephrotic presentation. Nephrotic presentation, which means there will be a massive proteinuria. The most important feature here will be the proteinuria. That will be more than 3.5 grams per day, and there will be hypoalbuminemia. There can be edema. There can be dyslipidemia. So we know that. So there will be a typical nephrotic presentation. And edema will predominate here. And as far as the class 6 is concerned, it's an advanced renal failure. They'll be presenting like a CKD kind of a presentation. Advanced renal failure. And they'll be typically presenting like a CKD sort of a presentation. And what will be the picture on light microscopy? Number 3. What are the findings you will see on light microscopy? As far as the light microscopic features are concerned, the class 1 will have a completely normal light microscopy, which means only if you do some electron microscopy or if you do some immunofluorescence testing, you will be able to find out this particular class 1 lupus nephritis. But as far as the class 2 is concerned, they'll be having this kind of a mesangial proliferation. That's why it's called a mesangial proliferative. So you can see that mesangial proliferation in class 2. As far as class 3 is concerned, typically they'll be having a picture called as APGN, that is called acute proliferative glomerulonephritis, which means most importantly, there will be cellular proliferation. Proliferation means that capillaries can proliferate. That's called endothelial proliferation. Your epithelial cells can proliferate. The proliferation is the characteristic feature. And this proliferation will be involving the entire glomerulus. If it's involving the entire glomerulus, it's called as acute proliferative glomerulonephritis, where there will be capillary proliferation as well as the epithelial cell proliferation. For example, if it is less than 50%, it's involving less than 50% of the total number of glomerulus that you see, that's called a focal proliferative. If it's going to involve more than 50% of the total glomerulus that you see, it's called a diffuse proliferative. For example, in a cut section in a slide, if you see some probably in this example, you have 7 glomerulus. If it is only 2 are involved, it will be focal. If it is 5 is involved, then I can tell it is diffuse, which means depending on the number of glomerulus in a particular section, a particular slide, and you count as an average, if it's involved, if it is more than 50% of the number that is involved, then it's diffuse. If it's less than 50% that is involved, then it will be focal. As far as class 5 is concerned, we know it's going to be base membrane thickening. Membranous means thickening of the base membrane. So that's a classical feature. And as the name suggests, class 6 will be a sclerosed glomerulus. Usually more than 80% of the glomerulus will be sclerosed by definition in advanced sclerosing type. So many areas will be scarred, and this is a CKD patient typically. They'll be like an ESRD, end stage renal disease for that matters. And next, moving on to the 4th, that is the immunofluorescence. Immunofluorescence plus or minus, like electron microscopy findings. What you see in immunofluorescence electron microscopy, you will see this typical mesangial deposits. Remember, even though the entire light microscopy is normal, in electron microscopy, you can still be able to make out this mesangial deposit. Even in immunofluorescence, there can be some mesangial deposits. And class 2 also, you will see mesangial deposits. The only difference between class 1 and class 2 is the light microscopy, where it will be negative normal in class 1 and it will be showing mesangial proliferation in class 2. If you take the class 3 and class 4, the classic finding is going to be the subendothelial deposits. That's what you see in class 3 and class 4 lupus nephritis. These subendothelial deposits can be focal as well as diffuse. At the same time, class 5 you'll be typically seeing subepithelial deposits because that is membranous nephropathy. You would have studied all these things in pathology. And class 6, I don't think there is any much to tell about class 6 in immunofluorescent electron microscopy because the glomerulus is already completely sclerosed. And then we can talk about the CKD risk. What is the long-term chronic renal failure risk? Risk of developing a chronic kidney disease, CKD risk. So class 1, very mild, you don't really have. Class 2, also very mild, you don't really have that much risk. Class 3, significant risk of developing a CKD is there. Class 4, in fact, very high risk of progressing to a CKD if you don't treat them. Class 5, again, significant risk. Class 6, I mean, I cannot tell anything because already it's a CKD patient. So what to tell regarding the CKD risk in this particular example? And as far as the immunosuppression is concerned, you need or you don't need immunosuppressive therapy. Immunosuppression is not needed, which means I'm telling not needed. Not needed immunosuppression here. Here immunosuppression is not needed again. Here yes, here yes, here yes, but here no, because already it's a CKD and there's no point in giving immunosuppression. Kidneys are already damaged. Unless until you transplant, there's no need for immunosuppression. As far as class 5 is concerned, you can be a little more conservative because here all you need is oral steroids plus probably a mycophenolate mofetil or probably a calcineurin inhibitor. Anyone you can start, but in general, we prefer steroids with mycophenolate mofetil. That is considered to be the best treatment. Oral steroids is enough here. But as far as the class 3 and class 4 is concerned, there is a high risk of becoming a chronic kidney disease. I can put another plus also here if you want to know. And at the same time, you need a high level immunosuppression because whenever the word proliferative comes, that's very important in nephrology. Whenever the word proliferative glomerulonephritis is there, if it's not due to infection, definitely we'll be needing high level immunosuppression. Like for example, when I write high IS, it means high level immunosuppression in the form of IV steroids like pulse methylprednisolone. Then they might be needing higher level immunosuppression like cyclophosphamide, even rituximab sometimes. So this is what we need. So high level immunosuppression in class 4 and class 5, but class 1, 2, and 6, they generally do not need any form of immunosuppression to be precise. And as far as the prognosis is concerned, okay, good, good, not so good, not so good, average, average, bad, so not so good. So these are the two diseases which produce worst prognosis, and in fact, this is the one that's going to have the worst prognosis of all. Clear. And there are some other points that is important with regards to lupus nephritis. What are things they'll be asking you? So first of all, this table will be very useful for you to tell different types of lupus nephritis, because in pathology you would have studied the names of different types of lupus nephritis, but you would not have been understanding easily. But this is quite simple. That's all. So these are the presentation, and this is what we want to know with regards to treatment, with regards to the prognosis and everything. So this is how a lupus nephritis is going to present in the first place. And there are 2-3 names that you need to know. The first one is what we refer to as something called a full house pattern. So that's very characteristic of lupus nephritis. What do you mean by full house? Commonly we use some immunofluorescent stains like IgG, IgA, then we use IgM, then C3, then C1q, then we use kappa chain, lambda chain immunofluorescence. So then fibrinogen stain. So we use certain stains for immunofluorescence. And as far as lupus is concerned, it will be staining everywhere most of the time. All the stains will be staining in the glomerulus, which means they will be having IgA, IgG, IgM, C3, C4, C3, C1q, kappa, lambda, fibrinogen. All these things will be having a positive stain. And at the same time, they'll be staining in multiple different areas. For example, even though I told predominantly you will subendothelial, subepithelial deposits, but there are certain subset of patients who will be having this kind of deposits everywhere in the different areas of the glomerulus, in the mesangial area, in the subendothelial area, in the subepithelial area, even in the capillary based membrane. So if this kind of staining pattern that is seen in every different area of the glomerulus and all the stains are staining, that is what we refer to as something called a full house pattern. It's a very characteristic feature of a lupus. Not so common, but still if you see that, that's very characteristic of lupus. Full house in immunofluorescence. Full house immunofluorescence staining. And if they ask you which is the lupus that you will most commonly encounter this full house pattern, it is class 4 again. Class 4 is the most common class of lupus nephritis where you tend to have a full house pattern. Second one, they used to call something called wire loop lesions, which is typically seen in light microscopy. These wire loop lesions are basically due to capillary proliferation, not specific for lupus. Any other proliferative disorder can produce capillary proliferation, but which is the commonest type of lupus where you will see capillary proliferation, and this kind of wire loop lesions is again class 4 lupus nephritis. That's the place where you're going to most commonly see the capillary proliferation. So 2 words, full house, wire loop lesions, both are important for exams. They ask you, these are very classically for lupus nephritis. Now, I think we have completed everything. So we have completed all the 10 organs, except for the GIT involvement, which is very rare in lupus. We have seen, I think, all the systemic manifestations of lupus nephritis. So now it's time to move on to our investigations. What are the investigations that you're going to do in lupus nephritis? Because there are a lot of questions on the antibodies that will come in lupus. But more importantly, the first is the acute phase reactants, APRs. Acute phase reactants, that's the first thing I'm going to talk about. There are 2 acute phase reactants. One is going to be the CRP and another is going to be the ESR. Both are considered to be acute phase reactants. But even though, you should not mislead by the term acute phase reactants, which means it's not like they will not be elevated in the long run. They can be elevated in chronic disorders also. But nevertheless, so there are 2 disorders. One is SLE and second is systemic sclerosis, that is scleroderma. What will happen to these values? So in SLE, it's very common entity to see a normal CRP even in a very active disease, but the ESR will be high. Whereas in systemic sclerosis, it's common to see a high CRP, but even in advanced disease, they tend to have a normal ESR. You might ask why, but we don't have extravagant answers, but we have some answers that you can tell conservatively better. So as far as SLE is concerned, the reason for CRP normalization is thought to be due to anti-CRP antibodies, because CRP is also a protein and SLE patients are known to produce antibodies, and majority of them tend to have this anti-C-reactive protein antibodies. Probably that is the reason why they have a normal CRP. Usually in active SLE itself, the CRP levels tend to be normal. But suppose if CRP levels are increased in a patient with SLE, that's the question there. If the patient is not having active SLE, but CRP levels are increased, which means SLE naturally does not increase CRP, even active disease. If the disease is not active, means I'm giving some immunosuppression, and even under immunosuppression, if my CRP is elevated, means it indicates an infection invariably. So this is a very important question. In SLE, CRP elevation is thought to be due to an infectious process. There will be some underlying infection. In systemic sclerosis, ESR is supposed to be normal most of the times. Suppose if ESR is increased in the setting of a scleroderma, then that is quite dangerous, because there could be a possibility of MCTD, that is mixed continuity disorder, or you have to suspect some underlying malignancy causing secondary scleroderma. That's possible. So always you should suspect either underlying malignancy or it indicates the patient might have a mixed continuity disorder. So this relationship is very important. So when CRP is elevated in SLE, what is the problem? And ESR is elevated in scleroderma, what is the problem? Both are very commonly asked questions in exam. Next, coming to the complements. So we need to test for the complements, of course. We know what are the classical complement pathway. In a nutshell, if you want to write the classical complement pathway, I can write C1q will activate C2, which will activate, I can write C4 then. So I think C1q will activate C4, which will then activate C2, which is going to activate C3, which is the common pathway. This is the classical complement pathway. And even an alternative complement pathway where we have this factor B and properdin, which is going to activate C3 directly, and this C3 will produce this terminal attack complex C5 to C9, and hence done. That's all. So C3 is what we refer to as something called a common pathway. We know that. From here, it's the common pathway. And this is going to be the terminal attack complex, TAC, or membrane attack complex. So in SLE, the most important thing is the activation of the classical complement pathway. So this will be activated to a great extent, so that the complement consumption will happen, especially in active disease. So if you ask about SLE, what will happen in SLE? What will be the complement status in SLE? They'll be reduced to C1q, they'll be reduced to C4, they'll be reduced to C2, and they'll be reduced to C3. So this is the characteristic finding, which means almost all the complements that you see will be reduced in SLE. But if there is a disease that's going to activate only the alternative pathway, for example, your bacterial components. So one best thing that activates the alternative pathway is the bacterial components. So for example, the best example for this setting is a PSGN. If you have a post-apical glomerulonephritis, you will have only C3 reduction. C3 only will be reduced. You will not have any reduction in the C1q, C4 and C2. They'll be completely normal. So that's how you differentiate this process from that process. And similarly, who's going to activate the alternative complement pathway is the antigen antibody complexes. And of course, there is no need to mention the fact that in SLE, there is tremendous antigen antibody complex formation that's going to definitely activate the classical pathway only. So this is the finding that you're going to see in SLE. But more importantly, whenever your C3 is low, that surely tells you that classical complement pathway is activated. But this C3 is not a reliable indicator. So I can write in one word, it's unreliable as far as SLE is concerned. C3 is sometimes a very unreliable indicator as far as SLE is concerned, because C3 is considered to be an acute phase reactant. So because it's an acute phase reactant, C3, its level can be falsely normal in active SLE. Even if the disease is extremely active, even if you are going to encounter an active SLE, the levels can be falsely normal in active SLE levels. Why? Because in active SLE, there will be two processes that is going on. Because it's an acute phase reactant, the C3 levels production will be increased. On the other hand, because there is simultaneous antigen antibody complex formation that is also accelerated in active SLE, and the complement consumption, which is also accelerated in SLE, you might basically result in normalization of the C3 levels, which means this excessive consumption that is reducing the C3 may be counteracted by excessive production of C3 because it's an acute phase reactant. So C3 may be maintained in the normal range. Suppose if they ask you what is the best thing to see in an active SLE, that is C1. C1 is basically the best, or you can use C4 also, not a problem. But C3 is not a very reliable indicator of active SLE or monitoring the disease activity. So it's always the C1. C1 is very important, or you can use other complements like C4 also. But C3 is not very reliable. And as I am talking about this, we didn't talk about one more important entity. As far as lupus nephritis is concerned, there are two antibodies that are very important. One is anti-dsDNA. This is the most important antibody, which is having a very important association with worsening of lupus nephritis and severity of lupus nephritis. If anti-dsDNA is in extremely high titers, the chance of having lupus nephritis is very high. And second antibody is anti-C1q antibody. This also has been shown to have a very high correlation with severe lupus nephritis. Remember, anti-C1q is associated with extremely high severity compared to anti-dsDNA, which is also associated with high severity of lupus nephritis. But anti-C1q is associated with extremely high severity. But nevertheless, this is a rare antibody. Anti-dsDNA is one of the very commonest antibodies that you encounter in the setting of a lupus nephritis or any lupus patient for that matters. So because I told about C1q, I suddenly thought about that, which I didn't tell. So now you will be knowing that this complements are also very important. Okay, in SLE. So how to understand these complements? Suppose you all might be having a question, or you might be all having a doubt. For example, sir, you're telling that there are low complements. Why can't it be a complement deficiency? You told like in SLE, the patients didn't have complement deficiencies also. How can I tell that it's due to complement deficiency or not due to complement consumption? That's the reason why if you have such doubt, you have something called a CH50, usually don't do. So this is a marker of complement activity, CH50. So whenever you have a reduced complement, CCH50. CCH50. If CH50 is increased, which means the complement activity. So what is CH50? The ability of the complement in the serum of a given patient to lyse the sheep RBCs, 50% of the sheep RBCs. Suppose if the complement activity is extremely high in the patient serum, definitely like the amount of sheep RBCs that can lyse is very high, the CH50 will be very high. That's what we refer to as a complement activity. So if it's a high CH50 in the setting of low complement, then you can think about complement consumption as the diagnosis. This is the diagnosis here, complement consumption. Suppose if I'm having a low complement with a low CH50, which means the CH50 is low, means low complement activity with the low complements that I'm seeing means it is complement deficiency and not complement consumption. So if at all you have a doubt between complement consumption as well as complement deficiency, you can do the CH50 and you can find out. This is a special test that is available. If you want, you can do. Otherwise, you may not do. Very commonly, commonly we don't do that. But if you have any doubt, you can do in that setting. Then the third one, we have the antibodies, which is actually very important, right? So antibodies in SLE. So antibodies in SLE, is something like a huge topic. I think it will take another 1 hour, half an hour to 1 hour for sure to talk about the antibodies itself. So first, let us see what are the antibodies that we're going to see. Number one, the first antibody that we do is a broad spectrum antibody. That's an ANA. This is the first antibody that you're going to do. That's anti-nuclear antibody. It's like a classroom of students. When you tell ANA, you can imagine like a classroom of students. So whether the classroom, the students are present in the class or not, if you see the classroom, if the students are there, you will tell yes. If you see the classroom and the students are not there, you will tell no. That's like ANA. But you cannot tell which student are there, whether that student is coming from a different class, or what student is causing what naughtiness, and which student is a topper, which student is actually a average student. You cannot tell just by seeing from outside. You know that the class is running, there is some students are sitting in the class. So ANA is like that. It's kind of a broad spectrum antibody. It's like under this ANA, you have a lot of other sub antibodies are there. That is very important. So ANA can be done by two tests. One is you can do ELISA, you can do ANA, or you can do immunofluorescence also. That's called IFA. You can do ANA through immunofluorescence as well. So if you do by immunofluorescence, you have some certain specific pattern. But I generally believe that ANA should be done in ELISA because I need to know what are the subtypes of ANA. But if at all you need to do by immunofluorescence, based on the immunofluorescence pattern also you can assume certain things, but even the immunofluorescence is not very specific for any particular antibody. But anyway, in exam they will be asking you, that's why we need to know about the immunofluorescence also. So whenever you do ANA and you're going to check the titers of ANA, remember only if it is more than 1:160, titer is positive in more than 1:160, it is considered to be like decent enough to tell that the patient is having some issue. If the ANA is still positive but the titers are very low, 1:80, 1:40, that doesn't mean really anything. So many common population like me, you also can have ANA in 1:40 or 1:80. So it doesn't mean anything. So only if it is more than 1:160, then we can call it as significant. Otherwise, it's insignificant. That's point number one. First of all, what is the importance of ANA? ANA is more of a screening test, which means it's having a very high sensitivity, approximately of 98 to 99% in SLE. But it's having extremely low specificity, which means positive ANA cannot confirm an SLE, but a negative ANA, you can use it to rule out an SLE. Patient is having a negative ANA, very, very unlikely to have a systemic lupus erythematosus. So that's what I'm going to see next. Suppose whether it's a positive ANA or if it's a negative ANA. If it's a positive ANA, then you have to work up further because ANA positivity cannot confirm an SLE. You have to look out other things, other antibodies. You have to group these antibodies. Then you have to see the clinical features, maybe kidney biopsy or skin biopsy. Do you have to do something to characterize? If the ANA is negative, then SLE is extremely unlikely. But if still in case of high suspicion, you can repeat ANA. Repeat ANA in this setting. If repeat ANA is positive, then again you can start working up because ANA positivity again does not mean anything. Suppose if the patient is having a negative ANA, even the repeat second time you did ANA, if that is also negative, then SLE highly unlikely here. So nobody will diagnose SLE after 2 negative ANAs. But if you still don't want to believe and if you still wanted to see whether it's really SLE or not, then you can do something called an anti-Rho antibody, that is SSA. If SSA is positive, again I'm going to work up further because that's again a non-selective antibody. If anti-Rho is negative, then probably like SLE ruled out completely. So it's not possible to have an SLE anymore. Hereafter, if you have suspicion, then it's only in dreams. In reality, you don't get an SLE. So remember, usually the first ANA itself makes the SLE extremely unlikely. If it is negative, that itself makes SLE very unlikely. If you still have doubt, you can do repeat an ANA. 2 repeat ANAs are negative, nobody is going to do anything further. And if the third time, if you have anti-Rho negativity, then again, hereafter, there is no possibility of SLE. So because there are very, very few case reports in the world which tell that there are certain SLE patients who can have SLE having only a positive anti-Rho antibody, but in very low titers. But apart from that, in reality, we don't do that. Fine. Antibody. Yeah, we found about ANA. And what are the important immunofluorescence patterns that you're going to look out for? So that's going to be the most important here. But before that, let us see the subgroups of antinuclear antibodies. So ANA can be subdivided. Before going to the immunofluorescence pattern, ANA can be subdivided into nuclear ANA and a cytoplasmic ANA. You can ask me, sir, how you're calling anti-nuclear antibody? How can you tell it's a cytoplasmic ANA? So yes, we have cytoplasmic ANA also. That's how it's been named. So nuclear ANAs are very important. The first nuclear ANA is, of course, going to be the anti-dsDNA. So antibodies against the double-stranded DNA. DNA is present in nucleus. That's why it's one of the types of anti-nuclear antibody. You have anti-double-stranded DNA. Remember, it's going to be extremely specific antibody, very, very specific for SLE. Even though on paper it is not the most specific, but it's extremely specific for SLE. But the problem is its sensitivity. Remember, the sensitivity of this anti-dsDNA is only approximately around 50 to 70% according to various studies. It's not present in all the patients, but if it is present, it's supposed to be very specific for systemic lupus erythematosus. In reality, even though on paper it's not the most specific, but in reality, whenever this antibody is positive, we take it as it's very specific for SLE. It is SLE unless proved otherwise. There are certain correlations with anti-dsDNA. Correlates. What are the things, clinical features that correlate with anti-dsDNA? I already told you one thing. That's the most important one. That is lupus nephritis. We have discussed already. Has a very good correlation with anti-dsDNA. Apart from that, it can correlate with lupus vasculitis, SLE vasculitis, and can also correlate to a small extent with neurological lupus. But the correlation will decrease in this aspect, but the most highest correlation is with lupus nephritis only. That's the most important point. And please understand, these anti-dsDNA are complement fixing antibodies. And another way, even though you can find out through ELISA, there is another immunofluorescence technique where you can find out anti-dsDNA. There's an immunofluorescence technique to find out anti-dsDNA selectively. That's called Cryptidia luciliae test. So this is a organism called as Cryptidia luciliae. So this Cryptidia luciliae, when you do immunofluorescence in that organism, if it comes positive, it is actually one of the confirmatory points to tell that anti-dsDNA is present for sure. So this could be a potential question. So how will you confirm anti-dsDNA presence in immunofluorescence? That is staining over the Cryptidia luciliae, anti-dsDNA. So because it is complement fixing only, because this antibody is complement fixing, you are getting all this nephritis, vasculitis, neurological involvement. So that is the reason. If it's not complement fixing, you will not be able to get all these things. And confirmatory is with Cryptidia luciliae only, but we don't do that. Usually we do ELISA, and if anti-dsDNA is positive, we take that as positive. That's for confirm, only for research papers. I did one SLE article, some 5 case reports I did, interesting cases in SLE in way back in 2013. During that time, I published that in BMJ, but that time, like they didn't accept the paper initially. Later on, they accepted. They didn't accept, and they came back and they written the mail saying that we want confirmation for anti-dsDNA. I really didn't know what is the confirmation for anti-dsDNA, because in my study, like I did a lab report which is showing that anti-dsDNA is positive. So later on, then I mailed, please tell in detail what to do, and they told they sent an article from their country saying that you need to do this Cryptidia luciliae test. And later on, I somehow searched and found it was done in Bombay in one center. So I sent there, and we get this test done, and the paper was published ultimately. But nevertheless, that's one of the confirmatory issues. We don't really do in real settings, but for research articles, if you want to publish, you need to do this Cryptidia luciliae that confirms the presence of anti-dsDNA. Then this Cryptidia luciliae assay is what we refer to as something called a FAR assay, FARR. FAR assay. That's another name given to that. Then moving on to the second one, second important antibody, that is the anti-histone antibody. Is also nuclear antibody only. As far as the anti-histone antibody is concerned, the sensitivity is little good. For example, if you have the sensitivity, it is 60 to 80% in setting of systemic lupus erythematosus, but the specificity is little less. It's poor. It's not specific for systemic lupus erythematosus. It can be seen in drug-induced lupus erythematosus. It can be seen in many other conditions also. Because of that, specificity is very poor. But it can have a good correlation with something called a DILE. That's called a drug-induced lupus erythematosus in appropriate settings. So you need to know that it's not only seen in SLE, it's also seen in the drug-induced lupus erythematosus areas, DILE. Then, what are the special features of this anti-histamine antibodies? One of the important special features, it is not complement fixing antibody. So because it is not complement fixing antibody, usually you will not get lupus nephritis, you will not get lupus vasculitis, you will not get neurological involvement. So why I'm telling that here itself? Why I'm telling here itself? Because in DILE, the only antibody, in fact, that you're going to see is the anti-histone antibody in drug-induced lupus. That is the reason why in drug-induced lupus, you don't see all these things. If they ask you what are the things that will not be seen in drug-induced lupus erythematosus, I will tell lupus nephritis, lupus vasculitis, and neurological involvement is not possible in drug-induced lupus, which is very common in systemic lupus erythematosus. So that is because of that antibody that is present, anti-histone antibody, which is not going to fix any complement. On the other hand, we have another antibody called anti-Smith antibody. Sensitivity is very poor, only 30% sensitivity, but specificity is very, very high. In fact, by definition, on paper, this is going to be the most specific antibody on paper. Most specific. If anti-Smith is positive, it is equal to SLE. That's all. And they do not have any good correlation with your systemic lupus, disease manifestations. So which means as far as the disease activity is concerned, it has a poor correlation, poor disease activity correlation, which means presence of this antibody will tell you it is SLE, but whether the disease is active or not, you cannot predict based on this. But it correlates with severe disease, that's all. Whenever anti-Smith is there, it means the disease will be severe, but it does not correlate with any particular disease state or any disease activity. Like anti-DSDNA, it cannot tell you. If anti-Smith is positive, you cannot really tell that the patient will be having lupus nephritis or something. It vaguely tell the patient will have a severe disease, but it cannot tell any particular manifestation, or it does not correlate with any clinical activity state. And we have an anti-Rho antibody. Anti-Rho antibody. As far as anti-Rho antibody is concerned, it's also referred to as something called an anti-SSA antibody. Anti-SSA. Why it's called SSA? Because it is originally found in Sjogren syndrome patients. SS means Sjogren syndrome, you know that. So it's originally Sjogren syndrome antibody. And again, this does not correlate with any disease activity. It cannot tell you whether the disease is active or not or inactive or not, but it correlates with certain manifestations. First of all, anti-Rho, and you have two antibodies, anti-Rho, and you have another antibody called as anti-La antibody, which is nothing but anti-SSB. Anti-SSB, basically. Both these antibodies can correlate with certain manifestations in patients with systemic lupus erythematosus. The first correlation will come with that of myositis. And we know that myositis is the reason for development of shrinking lung syndrome, and you can write that also. And second correlation is with photosensitivity. Whenever anti-Rho or anti-La is positive, the patients will be having severe photosensitivity. And the third one is the myocarditis that can have a correlation with anti-Rho antibody. Next is NMO spectrum disorder, NMOST, that can have a good correlation. And they also have a correlation with something called SCLE. I think I've told you that already. That is subacute cutaneous lupus erythematosus. Then it has also a good correlation with your neonatal lupus. So if a pregnant mother is having anti-Rho antibody or anti-La antibody, this SSA and SSB antibodies, irrespective of the disease, it could be Sjogren or it could be SLE, doesn't matter. If a pregnant mother harbors anti-Rho, anti-La antibodies, there is a 2 to 5% chance that the child will be born with neonatal lupus. And there is also a 2 to 5% chance that this child who is born with a neonatal lupus will develop a complete heart block. And usually this complete heart block tend to be permanent, which means this complete heart block needs pacing. You cannot treat conservatively. So that's a small risk that is present in the child who's going to be born with neonatal lupus erythematosus. And out of all these things, more importantly, you have two different types of anti-Rho and anti-La. So you have one is the 60 kilodalton form, There's a heavy chain form, and we have the 52 kilodalton form, which is a lightweight form. You can write 52 kilodalton. And they will ask you in exam which is the one that is correlating with neonatal lupus. It is the 52 kilodalton form. That is the one that correlates with the development of neonatal lupus, to be precise. This is the one that is going to correlate with neonatal lupus, not the 60 kilodalton form. On the other hand, one more entity is there, that is reduced risk of lupus nephritis. This antibody does a lot of things very bad, but there is one thing it can do good is the presence of these antibodies tell that the patient may have a reduced risk of lupus nephritis. Nephritis risk is less. But all this initial manifestation which I have told you correlates with Rho better than La. But the last manifestation alone, reduced risk of lupus nephritis, correlates with La better than Rho. That's all. Some of the important points that you might be needing to know with respect to anti-Rho and anti-La antibodies. Then we have the fifth nuclear antibody, that is anti-U1 RNP antibody. This is a ribonucleoprotein antibody, which is again a nuclear antibody only. As far as anti-U1 RNP is concerned, it is more sensitive in MCTD patients. It's not specific, it's sensitive for MCTD, that is mixed CTD, mixed connective tissue disease. It's not specific for even for MCTD. It's not specific for SLE also. If in SLE, if it is present in SLE, it correlates with Raynaud's phenomenon. It correlates with Raynaud's phenomenon, and it also correlates with esophageal dysmotility that is seen in scleroderma. It correlates with esophageal dysmotility. Usually happens in scleroderma, but if this antibody is present in SLE, that correlates with these two features. One is Raynaud's, and second is the esophageal dysmotility, but it is actually quite sensitive for diagnosis of MCTD, mixed CTD. And remember, this anti-Rho and anti-La are originally Sjogren's syndrome antibodies, which means they are more sensitive in Sjogren's syndrome patients. They are more sensitive for Sjogren's syndrome diagnosis rather than your SLE diagnosis. Anyway, to start with. In SLE, I mean, not in SLE, anti-Rho and anti-La can correlate with any of the manifestation, any disease. Irrespective of the disease, these antibodies will correlate with some manifestation which I've told you already. Then we have the cytoplasmic ANAs. What are cytoplasmic ANAs? The most important cytoplasmic ANA that they're going to ask is anti-ribosomal protein antibody. Ribosomes are in the cytoplasm. Of course, this ribosomal protein antibody will be a cytoplasmic ANA only. This is reasonably selective, I mean specific for SLE, decently specific enough. But more importantly, it will correlate with one important manifestation. Anyone wants to tell? Sensitivity is very low, only 15% or 20% max. But it correlates with one important manifestation in SLE. What is that manifestation? I just want to know whether people are not sleeping. That's why. We discussed that already, isn't it? Yes, behavioral manifestations. So it has a good correlation with behavioral manifestations in systemic lupus erythematosus. That's anti-ribosomal protein antibody. And what many people don't know is it vaguely correlates with something called a lupus hepatitis. SLE can rarely cause hepatitis. It can correlate with lupus hepatitis as well. That is the second one. Then we can have anti-phospholipid antibodies. That's called APLA antibodies. We'll be discussing in detail what are the APLA antibodies. APLA antibodies can correlate with thrombosis, thrombocytopenia, and recurrent pregnancy loss, RPL. Currently we call it as bad obstetric history, or I can simply call it as recurrent abortions, recurrent pregnancy loss, especially in the second trimester. These are three things that these APLA antibodies are going to correlate with. So then we have certain cell surface antibodies in SLE. These are not basically called as ANAs, but you can write separately also. But because of I want to constrict everything in this small space, I'm trying to write here also. Cell surface antibodies. What are cell surface antibodies that you can see in SLE? One is the hematological antibodies, anti-erythrocyte antibodies, which correlates with autoimmune hemolytic anemia. Then we have anti-lymphocyte antibodies that correlates with the leukopenia and lymphopenia that you see in SLE patients. And we have anti-platelet antibodies, which correlates with the presence of thrombocytopenia, that is secondary ITP in patients with SLE. And apart from that, we have other antibodies like anti-neuronal antibodies also, which correlate with the diffuse manifestations of lupus, like headache, seizures, and all. So anti-neural antibodies, diffuse manifestations, diffuse neurological manifestations in lupus, we discussed already. So that correlates with anti-neural antibodies, which is also basically a cell surface antibody only. Clear? So I think we have discussed all the antibodies and their important correlations. So nuclear, cytoplasmic, cell surface, these are 3 different types of antibodies. And ANA is a broad spectrum, as I told you. Then we have something called immunofluorescence pattern, which is also important. So in exam, but this is not really important according to me, because immunofluorescence pattern, we can predict only that particular kind of a disease. It's only a prediction, but it cannot tell you what is the exact disease or what is the exact antibody that is associated with that kind of particular pattern. Let us see what's going to happen. So as per the immunofluorescence pattern, whenever you tell ANA is positive, which means you need to tell, if you do by immunofluorescence, then you have to tell the pattern. If ANA is positive, then you definitely have to tell the pattern. If you're doing by immunofluorescence. LSR, then that's a different entity. But if you do by IF, then you have to tell the pattern. What is the pattern you're seeing? Based on the pattern that you see in the microscope, you can classify into 5 different patterns. One is going to be the, first we are talking about the nuclear pattern. So we have cytoplasmic patterns also, which I'll be showing in some time. So as far as the nuclear patterns are concerned, the first one is the homogeneous pattern. There's the number 1 pattern, and the second pattern is the peripheral pattern, or otherwise referred to as something called a rim pattern in immunofluorescence. In general, in our hospital, we don't really do immunofluorescence as much as possible because it gives a lot of confusion. But nevertheless, if you specifically want to see, you can see. The labs are still doing it. And the third one, we have something called as a speckled pattern. So I can write here, this is a speckled pattern. And the fourth one, we can call it as something called a nucleolar staining pattern. Nucleolar pattern. And the fifth one is the centromeric pattern. Centromeric pattern. Of course, everyone would have studied in pathology itself already, because nowadays, like every pathology teacher is basically teaching this. It's not very important, but still they are teaching it, so it must be easier for you. As far as the homogeneous pattern is concerned, you're going to see kind of a homogeneous appearance. Remember, when you take a cell in SLE, for example, let me show some immunofluorescence pattern. So this is an example of a neonatal lupus. If you see here, there's a classic example of neonatal lupus, and the lesion, what you're seeing, is due to anti-Rho antibody. Neonatal lupus means it's due to anti-Rho only. Anti-Rho antibody will also produce this SCLE type lesions. That's called subacute cutaneous lupus erythematous lesion, and this is how it looks like. This kind of annular polycyclic lesions. Some lesions may be of target type lesions also. That's called as Rowell syndrome, which we've seen already. Example of neonatal lupus. And if you see this one, this is a typical immunofluorescence pattern that you get. The first one is homogeneous pattern. We know that. And what you see here is actually the nucleus. That's the only thing you see. Basically, you don't see the cell outline here. Because they're staining only the nucleus, you don't really see the cell outline. So that's very important to know, basically. So what you see here is typically only the nucleus. You don't see anything else. These are only the nucleus. This is not the entire cell for that matters. So many times you might be confusing. So where is the cell then? And where is the nucleus? This is only the nucleus. Because the cytoplasm is not stained, you're not able to see the cell surface. And the cellular membrane and all you're not able to see. Which means only the nucleus is stained there. That's why these antibodies are called as anti-nuclear antibodies, because they stain only the nucleus. So first is homogeneous pattern. As I showed you in the beginning, homogeneous pattern means you'll be getting something like this. You'll be getting a complete staining of the nucleus, so which means I can write like this maybe. I can draw like this. So this is a complete staining of the nucleus. Entire nucleus will be stained. That's a homogeneous pattern. Diagnosis. What diagnosis you want? Niraj is asking for diagnosis LSI is enough for IF must. What diagnosis you are expecting? Tell me, then I will tell the answer. For diagnosis of SLE, if you ask for diagnosis of SLE, I just need ELISA. That's more than enough. Anyone is enough. But I generally prefer ELISA, and many of the guidelines also telling ELISA is better. That's what we do. That's what we prefer also. I'll come back to your answer later on. So we have this homogeneous pattern. As far as the homogeneous pattern is concerned, there can be two antibodies that can produce this pattern in general, but there are many antibodies that can produce this pattern, but 2 antibodies classically produce this kind of homogeneous pattern in IF. One is the anti-dsDNA antibody, and second is anti-histone antibody. I think we need not discuss anything about anti-dsDNA and anti-histone from now on. We have seen enough about anti-dsDNA and anti-histone. Traditionally speaking, whenever you get a homogeneous pattern, they tend to differentiate the antibodies based on the complement fixation test. We know whenever complement, if it's complement fixing, we call it as anti-dsDNA. If it's not complement fixing, we're going to call it as anti-histone antibody. But traditional way. But currently we have ELISA. We can easily find out. So what is the type of antibody? Because we have specific antigens. If that is precipitating, then we can find out the specific antibody through ELISA. That's the advantage. As far as the peripheral or rim pattern is concerned, usually it goes towards only one antibody in reality, that is anti-dsDNA antibody. So that's why sometimes just to confuse you, because this has absolutely no clinical relevance, just to confuse you, they will tell among all the patterns that you see in SLE, immunofluorescence patterns, which is the pattern that will be specific for SLE? That's what they will ask. This is to confuse you, completely to confuse you. They will ask you which of the following patterns is actually specific for the diagnosis of systemic lupus erythematosus. If that pattern is there, then it means SLE is confirmed. So they will ask you this kind of question. So the answer will be anti-dsDNA in that setting. That is absolutely nonsense question, and but just to confuse you, maybe just to test your background and basic understanding. That's all, nothing else. So as far as the speckled antibody is concerned, we have 2 types of speckling. One is called a coarse speckling is there. Coarse speckling is there, and we have fine speckling is there. Very difficult to see all this unless until the pathologist is extremely experienced. So as far as coarse speckled antibody is concerned, there are 3 antibodies that can be coarsely speckled. One is the classic anti-U1RNP antibody that can produce this kind of coarse speckling. And second antibody that can produce this kind of coarse speckling is anti-Smith antibody. And the third antibody that can produce this kind of coarse speckling is your anti-SEL70. We'll come back to that. Then fine speckling is there. What are the 2 antibodies that produce this kind of fine speckling? Then we have something called anti-Rho antibody, anti-La antibody. The first one I can write anti-SSA, that is anti-Rho antibody, and second one we have anti-La antibody. These are the SLE antibodies that are going to basically produce something called this kind of a fine speckling pattern. But there are other antibodies that can produce this kind of speckling pattern. You know, these are the SLE associated antibodies. You know what is anti-U1RNP antibody? We have discussed already. That's associated with something called miscellaneous continuity disease in SLE. It can be present, but it's not specific. It does not correlate with any particular manifestation that much. We have studied already. An anti-Smith antibody, the most specific. It can still produce the same coarse speckling pattern. Anti-Rho we have studied, anti-La we have studied, but it can be associated with 2 more antibodies. Especially the fine speckling can be associated with something called anti-Mi2 antibody, which I'll be speaking about that late in the session. When I talk about dermatomyositis, this antibody is associated with something called a Schall sign in dermatomyositis. We'll study about that. That is anti-Mi2 antibody. And apart from that, we have another coarse speckling antibody that is anti-SEL70 antibody. This is otherwise referred to as something called an anti-topoisomerase 1 antibody. Remember, this antibody is not even related to systemic lupus erythematosus. This is in fact related to something called diffuse form of systemic sclerosis. We know that. So which means this speckled pattern is not specific for any particular disease, but whenever speckled pattern is there in a immunofluorescence, it tells you there is some form of connective disorder. It tells it's actually specific for some CTD. In the sense, like this speckled pattern means there is some CTD, some connective tissue disorders. That could be scleroderma, it could be dermatomyositis, it could be Sjogren syndrome because Rolla is also there. It could be SLE, it could be MCDD. So what I'm trying to tell is, as a broadly, if you want to tell which pattern correlates with some form of CTD, which means it's sensitive, which pattern is very sensitive for some form of CTD, I'll tell it is a speckled pattern only, because that is the one that correlates with some form of definite form of CTD for sure. But we cannot tell, but even though it's not specific, but it's sensitive, we cannot really tell what CTD that the patient is having. That's the idea with speckled pattern. I mean, we'll be discussing in detail with regards to the anti-SEL70 antibody after some time. Then we have a nucleolar pattern of antibody. Nucleolar pattern, we have 2 patterns. One is called a clumpy nuclear pattern. Second one, we have something called as a homogeneous staining of nuclear pattern. This clumpy staining is associated with something called anti-U3RNP antibody, that is called as anti-fibrillarin antibody. That's a clumpy staining. clumpy nuclear staining, that is antifibrillary, which is again associated with systemic sclerosis, not with SLE, especially the diffuse form of systemic sclerosis. We'll be studying about that in some time. Then we have a fine nuclear pattern or homogeneous nuclear, or I can write as homogeneous nuclear staining or a fine nuclear staining. So if it's homogeneous nuclear pattern, then usually associated with one important antibody called as anti-PMSCL antibody. This is also referred to as an overlap antibody because there are some overlap CTDs like polymyositis scleroderma overlap will be there. In those kind of overlap syndromes, this is the antibody to see for. And that will also produce a nuclear pattern. Two antibodies for nuclear, one is anti-U3RNP and second is anti-PMSCL. Then this is a very common question asked in exam. As far as centromeric pattern is concerned, as far as exams, only one thing you need to know. It's associated with anti-centromeric antibody. Of course, the name itself suggests anti-centromeric antibody, otherwise referred to as ACA. So you know where it's going to be present. It's going to be present in limited variety of scleroderma, limited forms of scleroderma. That's called limited SCL. Remember this again, diffuse scleroderma. This again is likely to be a diffuse scleroderma, and this one is with dermatomyositis, and this, as a name suggests, is in overlap syndrome. This is for limited scleroderma. Fine. So these are the different immunofluorescence patterns that you see, but really difficult. Like you need a lot of experience to tell what is the type of antibody that is present, to differentiate between coarse, fine, clumpy, homogeneous, peripheral, rim. You need a lot of experience. Apart from that, still, if you find out a particular pattern, it's not going to really tell what is the type of antibody that you encounter. I mean, I told you only the most appropriate antibodies that could be present in a particular type of pattern, but I didn't tell you this is going to be the only antibodies that will be seen. In fact, a lot of other antibodies can produce these kind of immunofluorescence patterns, which gives you a tremendous confusion. And this immunofluorescence patterns will be an approximation rather than a confirmation of what antibody that is seen. So they cannot really tell what antibody is definitely present in the patient. So to confirm, always you have to look back at the ELISA only. That's why currently we always prefer doing an ELISA rather than doing a IFA. Remember, compared to ELISA versus IF, advantages and disadvantages are there, which means each and everything has advantages. If you go for ELISA, the specificity will be more, which means you can find out the exact specific type of antibody. The type of antibody will be more, and specificity will be very high. If you do an immunofluorescence, it's very difficult to lose, like this kind of antinuclear antibodies because they're extremely sensitive, which means any antinuclear antibody, if it's present, it'll show some staining in the nucleus. So that's why IF is highly sensitive, whereas ELISA is highly specific, and it can tell you the particular type of antibody, exactly what antibody is there, but staining cannot tell. It can only approximately tell, but nevertheless, staining is extremely sensitive. That's why many rheumatological guidelines, if you take, they will tell to start with, if you want to do an ANA testing, go for IFA to start with. So once you know ANA is positive in a particular titer, if it's significant enough, then go for ELISA to find out what is the particular type of antibody that you have. So in that, IF really fails. But nevertheless, this pattern, I don't know why they are asking, it's of no diagnostic use, to be honest. Then you have a particular type of cytoplasmic staining also. We need to know about cytoplasmic staining. What are the cytoplasmic stainings? I think I can write separately, or maybe I can write a little bit of down. There's some 2-3 cytoplasmic stainings that you need to know, which means there are cytoplasmic ANA stainings because of cytoplasmic antibodies are also there. So you can have this kind of, what is that? Cytoplasmic speckled pattern. Number one is cytoplasmic speckled. So this speckling can be again a fine speckling or probably a coarse speckling. If you see a cytoplasmic fine speckling, it usually goes towards the presence of anti-Joan antibody very commonly. Where you see that you'll see in polymyositis, typically anti-Joan antibody. Anti-Joan antibody will again come under a spectrum of a different group of antibody called anti-amino-acid tRNA synthetase group of antibodies. Anti-Joan is only a part of that anti-amino-acid tRNA synthetase antibody, but it is these amino-acid tRNA synthetase antibodies means they belong to a larger group of disorders. Currently, even though books called polymyositis, currently they belong to a larger group of disorders called synthetase syndrome. And it is believed that currently this polymyositis is only one of the component of the synthetase syndrome. So the bigger pattern is the synthetase syndrome that you get, but all the antibodies that coming under the synthesis syndrome, one of the antibodies is anti-Jo1, I told you, and one of the picture in the synthesis syndrome is polymyositis. That's what the current idea is. So they can ask anything. And if you see a coarse speckled pattern, or if you see a clumpy pattern, clumpy speckled pattern in the cytoplasm, this usually goes towards something called an anti-mitochondrial antibody. You have many different types of mitochondrial antibody. If it is a M2, AMA M2, against the M2 mitochondrial component, or usually it is against the pyruvate dehydrogenase complex. We know if it's against the specific M2 complex of the pyruvate dehydrogenase complex, that is specific for a disease called a primary biliary cirrhosis, that is PBC. Or else it's not specific. So if it's against M2 component and you have to find out through ELISA, if that is the case, then it is specific for primary biliary cirrhosis. And second, we have something called a rods and rings sort of a pattern. Cytoplasmic rods and rings. Cytoplasmic rods and rings is very non-specific, and it can be associated with interferon alpha therapy, some HCV infection, so many things. It's very non-specific. That's called cytoplasmic rods and rings. That's all. So let us see some of the patterns which I've told you. So first one is going to be the homogeneous pattern. I can see this kind of homogeneous sort of a staining here. This homogeneous pattern. Then of course, this is a type of a speckled kind of a pattern. If you see, they're staining the nucleus, but not staining the nucleus specifically, but they're producing this kind of speckled appearance in the nucleus. Whatever you see are the nucleus, as I told you. So this kind of dot speckling is basically speckle type. One is the coarse speckling on the left side and fine speckling on the right side. Difficult to differentiate, but still, at least you must be knowing enough to diagnose that it's a speckled pattern. And this is a kind of a centromeric pattern. So you will see like clumps of stars in the sky. So it's very characteristic. This is a centromeric pattern. Whatever they are staining are basically the centromeres. And you can see that these are the centromeres that are involved in mitosis. So that's a cell that is undergoing active mitosis there. So that's why you are seeing a centromere like that. So in mitosis, all the centromeres will be in the center, you know that. That's why they're looking like that. So that's a centromeric pattern, very classical if you see something like that. And then you have this nucleolar pattern. One is the clumpy nucleolar on the right side and a little bit a fine nucleolar on the left side. So anyway, this is a nucleolar pattern because they are staining only the nucleolus predominantly within the nucleus. Clear. This is a nucleolar pattern. You know what are the antibodies that are associated. Then, of course, we have this form of staining. So this is the peripheral rim pattern. You can see this is the nucleus that you're seeing, and only the periphery rim of the nucleus is getting stained. Rim of the nucleus is getting stained. So this is a peripheral or a rim pattern that we generally tend to get. And if you see this kind of pattern, this is basically a cytoplasmic ANA, a cytoplasmic pattern, which means the nucleus basically is not stained at all here. It's the cytoplasm that is getting stained. So this is a cytoplasmic pattern. If you see this sort of clumpy cytoplasmic staining. So this is the best example of a Jo1 pattern. For example, this is another example of a fine cytoplasmic speckling, which is basically telling you that it's anti-Jo1 very commonly, but there could be a lot of other antibodies. But this kind of clumpy, this is a nucleus. Here it is not stained at all. You see this kind of clumpy cytoplasmic staining. This is basically suggestive of AMA, anti-mitochondrial antibody. If it is against M2 component, that becomes a little specific for primary biliary cirrhosis. And finally, you have the cytoplasmic rods and rings. These rods, rings are there. So that is very non-specific kind of a pattern. So you have multiple different immunofluorescence pattern to begin with. So immunofluorescence is not specific for any antibody, but it can be quite sensitive. If you do only ANA, it is very sensitive. That's all. For that. Clear? Fine. So criteria wise, you don't follow the ACR criteria as of now. We follow the SLIC criteria only, which is based on two things. One is the clinical factors, and second, they take care of the immunological features also. Both these things has to be there to tell that the diagnosis is SLE, systemic lupus erythematosus, according to the latest SLIC criteria. Similarly, initially what ACR, you need to know the difference, then only you will understand. So when you start with the ACR criteria first, they gave a I mean, 1 to 11 points were there. In this 11 points, if you, like tell 4 out of 11, if it is present, anything more than that is equal to SLE. That's what they told. Later on, they revised it, telling that you need a ANA positivity also to tell it's an SLE. Because we know that if ANA is negative, it cannot be SLE, irrespective of the clinical features that you see. So then only you will call it as an SLE, because ANA is a very integral component. That's from the pathophysiology to the treatment. ANA is a very important thing. So based on that, just presence of 4 clinical features without ANA positivity can't tell SLE. Then they revised it, telling that ANA positivity is important. They revised it in 2005, telling revised ACR criteria, ANA is needed to diagnose SLE. But even that had a lot of pitfalls. So later on, the SLIC came, SLICC came in 2011. Then they revised it in 2015, as I told you. So where they told clinical criteria separately, and you need immunological criteria mandatory, which means you need certain clinical features also, and you need some immunological features, which means overall, if you take overall, there are many criteria under clinical and immunological, but overall you need at least 4 to tell that the patient is suffering from SLE. But they told mandatory at least 1 clinical feature should be there, and at least 1 immunological feature should be there. So this is what they told. At least 1 should be on either side minimum, but overall 4 should be there. I mean, if you calculate as a whole, so then only you can call it as a systemic lupus erythematosus. Even then, that had a lot of pitfalls. Then they revised it again, saying that biopsy proven lupus nephritis can be treated like an SLE. Biopsy proven lupus nephritis can be treated like a systemic lupus erythematosus. That's why I'm trying to tell that these criteria will be confusing and they will be changing from time to time. So what does not change is the disease. What does not change is the problem that they're going to give to us clinicians. These things are not going to change anyways. So the idea is don't be a criteria freak. That's all, because it's a common tendency to orient towards criteria at a younger age. Whenever you're a undergrad student or a postgrad student, you always think about criteria. So I need these criteria to know. But before that, whenever you learn a particular criteria, it's always important to remember one thing, that understand this is only to picturize the whole information. At the same time, this is only to understand the disease better, rather than like understanding the patient. So patient can come in any form. They need not necessarily fit the criteria, even if they have the disease. So see the patient. That's the most important thing, rather than looking after the criteria after criteria after criteria. So don't try to mug up all these things. And this is of no use, of course. Certain things are important for exams, but nevertheless, even that things I don't think they're important for clinical practice. As far as SLE management is concerned, because we need to treat SLE now, how we are going to manage a patient with a systemic lupus erythematosus. As far as treatment of SLE is concerned, we can construct the same kind of a table, like construct the regime like we did for rheumatoid arthritis. So let us start with the basic regime. This is a basic bedline therapy, which is called as base therapy or bed therapy. And one of the important drugs, first thing I'm going to use in any patient with SLE is HCQ, hydroxychloroquine. Hydroxychloroquine, first of all, you need to understand it is not immunosuppressive drug. It's more of an anti-inflammatory drug. And clearly hydroxychloroquine has proved in many trials, telling that irrespective of the disease stage or irrespective of the severity of the disease, they reduce the number of flares in systemic lupus erythematosus. At each flare, the organs are going to get more and more damage. So reduce flares means it's definitely good. So number of flares you're going to reduce if the patient is on continuously on hydroxychloroquine, definitely is going to be less. That is why any patient with proven SLE, hydroxychloroquine forms the basic therapy, bed therapy. It has to be given. That's a rule. As a rule, you have to start, because they're going to reduce the flares. Number of flares will be reduced. Apart from that, there are a few things that you need to know. For example, sunscreens are important, because most of the lesions in SLE are phototherapy, and avoid going out in the sun. Especially, like we tell them, avoid sunlight between 9 a.m. to 4 p.m. That's a timing where the UV rays will be maximum. So don't go out from 9 a.m. to 4 p.m. as much as possible, because to avoid the photosensitivity that can increase the apoptosis and increase the risk of flaring over skin lesions as well as the underlying systemic lupus. Where I can use plus or minus NSAIDs. I can use plus or minus NSAIDs if they're having musculoskeletal manifestations, or I can use plus or minus a low dose prednisolone if the patient is having musculoskeletal features. So maybe I can write separately, I think, rather than writing here. We can write separately. You have HCQ as a basic bed therapy. Then suppose this is a basic therapy base that we are going to create: sunscreens, avoiding sun, HCQs, and after that I can write that if the patient is having additional musculoskeletal issues, because musculoskeletal issues are extremely common. The patient is having additional musculoskeletal issues that is not getting controlled with HCQ, then I can give PRN. PRN means whenever needed, I can give NSAIDs to the patient, but you have to keep monitoring the kidney function, of course. Plus or minus, I can give low dose corticosteroids. Typically, we use prednisolone SLE. When you call low dose prednisolone, if the dose required is less than 20 milligram per day, if you start with a prednisolone of less than 20 milligram per day, we are going to call it as a low dose prednisolone. So additionally, it might be needed. Suppose if the musculoskeletal symptoms are not getting controlled with our routine treatment, still the patient is having severe musculoskeletal manifestation, which means the patient is having severe arthralgia, severe myalgia, severe fatigue, not responding to the basic treatment. So which means I can write MSK manifestations, musculoskeletal manifestation not responding to routine treatment, the basic treatment that you have given till now. So then in this setting, I can move on to something called a moderate dose of prednisolone. Moderate dose of prednisolone can be tried in this setting. One more thing I can do here is, one more thing that will be very helpful in this situation is something called a belimumab. This is an approved drug for this kind of moderate musculoskeletal manifestations. Belimumab can be tried in this setting, and belimumab will be effective if antibody titers are very high, especially with regards to anti-dsDNA. The antibody titers are very high, anti-dsDNA titers are very high, then belimumab will be very helpful. But nevertheless, belimumab is only for moderate disease, not for severe disease. Now we are going to the next part of the regime. That is, you are constructing more. So now you're going to add more therapy. So in the setting, if the patient is having a severe disease, so now we had moderate disease, now the patient is having severe disease. What do you mean by severe disease? The patient is having some kind of systemic organ involvement. So what are the organ involvement that you can have? For example, the patient is having renal involvement, typically in the form of severe lupus nephritis, class 3, 4, and 5. Then second, if the patient is having a kind of CNS involvement, that is neurological lupus, or the patient is having severe hematological manifestations. Like for example, the patient is having severe hemolytic anemias and severe ITP, secondary immune thrombocytopenic purpura. So in this setting, you need to give definitely high dose immunosuppression. High dose immunosuppression is definitely required. High dose immunosuppression means definitely I'll be using like IV methylprednisolone, but it depends on what is the problem that you're going to encounter. Suppose if it's a severe renal involvement, in this situation, I'm talking about a class 3, 4 lupus nephritis. I know I'm going to start with pulse dose IV methylpred. Plus I'll be usually starting with the cyclophosphamide in this patient. Suppose if it's a class 5 lupus nephritis, then I'll be giving oral prednisolone at a very high dose, 1 milligram per kilogram. Plus I can use a MMF, that is mycophenolate mofetil. This is a usual treatment that we start with membranous nephropathy. But we know that class 1, 2, and 6 does not necessarily need any treatment. If it's a CNS involvement also, then I can use pulse methylprednisolone. Plus probably I can use a cyclophosphamide if it's a severe CNS involvement. So even in this setting, I can start with this. If it's a severe hematological involvement, most of the time I can give steroids. It can be IV or oral depending on the severity. Steroids are very important. If still you see a refractory disease, despite you give a steroids, you can try IVIG in this setting, 2 gram per kilogram. IVIG in this setting for hemolytic anemias and ITP. IVIG does give a very good response because they are due to antibodies. Once you clear these antibodies, hemolytic anemias and ITP do respond to a very good level. So when you call a high level immunosuppression, whenever you use high dose prednisolone equivalent of probably more than 40 milligram per kilogram, or I wrote 20 milligram per kilogram or what? No. When you are using a prednisolone of more than 40 milligram per day, or when you are using approximately 1 milligram per kilogram per day. So this is what we refer to as a high dose prednisolone. So that always indicates a severe disease. When the patient is on high level immunosuppression, most of the time you will be needing other additional drugs also, like cyclophosphamide, to control the organ involvement and organ damage. And there are certain other things that we'll be needing in setting of SLE patients. For example, if the patient needs IVIG. So if somebody asks you what are the need for IVIG or probably plasma exchange in patients with SLE. So what will you answer? The first thing I can tell, refractory cytopenias. I can write in a bigger way. So these are additional options. Maybe I can write in a different color. So these are additional options that you have. If you want, you can give. Otherwise, you need not give. So what is the role of IVIG? So IVIG as such, the only indication that we use is in refractory cytopenias, where you can use IVIG. And second thing what we have is plasma exchange. Plasma exchange. What are the indications for plasma exchange, as well as, whenever you think about an SLE. So number one indication, I told you, about vasculitis, which we'll be discussing, but the number one indication of plasma exchange is diffuse alveolar hemorrhage, DH. And second is NMO spectrum disorders, NMOSD. And probably in the setting of severe RPGN, rapidly progressing glomerulonephritis, that is otherwise referred to as crescentic glomerulonephritis. In these settings, I'll be starting with the plasma exchange. This is an add-on therapy. This is an additional therapy, not always needed. Only in the settings which I've told you, you might be needing to start with. And finally, you have some additional options that you can give, which are approved recently. What are the additional options? These are like targeted therapy. So on top of it, so if you have some scope for all these things, you can start. For example, number one is you have this combined anti-IL-12 and IL-23 inhibitor that is called as ustekinumab. So I'm not going to write what is the mechanism of action. You know what is ustekinumab. You can start under certain specific indications are there, but we need not know. Second one, we have some JAK inhibitors like baricitinib is there. How tofacitinib is approved for rheumatoid arthritis. Similarly, baricitinib, it's a JAK inhibitor, is approved for use in systemic lupus erythematosus. Then there is interferon alpha inhibitors, IF and alpha inhibitors. Already we discussed there are two interferon alpha inhibitors. One is rontalizumab and second is siflimumab. Siflimumab is already approved for treatment in SLE. And number 4, you can use anti-CD20, rituximab. Is also to a great extent approved in SLE. So when you use rituximab, because rituximab being a very common drug, you are going to use in refractory lupus nephritis, which means the original therapy which I told you is not working in lupus nephritis. You can use rituximab. Remember, lupus nephritis will be usually due to the anti-dsDNA or anti-C1q antibody. So rituximab will be effective in that setting because it reduces the production of antibodies from the B cells. So refractory lupus nephritis, you can use rituximab. And you have a second anti-CD20 that is approved, that is ocrelizumab. That's a newer anti-CD20. Even that is approved for the patients. And the sixth drug is anti-CD22, that is called epratuzumab. Basically, epratuzumab is anti-CD22, epratuzumab. And we have something called anti-CD20, that is this rituximab and ocrelizumab. I think ocrelizumab, we have spoken about that in multiple sclerosis as well. It's approved in multiple sclerosis also. Ocrelizumab is approved in SLE also. So these are the two newer anti-CD20s. And epratuzumab is basically anti-CD22. So these are the options you have. These are the biological options. These are targeted therapies. And you need to know. So when you call it as mild MSK symptoms, you have definition like fatigue, constitutional symptoms, serositis, arthritis, arthralgia, rash, arthralgia. So if these are going to be the usual things, these are the things you are going to encounter, only this, then these are considered as mild symptoms. So in mild symptoms, your bed therapy is more than enough, plus you give a load of steroids, that is going to be more than enough. You're talking about guselkumab or guselizumab. If there is guselizumab, I don't know, maybe pharmacology professors might have told some new drug. As far as the monoclonal antibody is concerned, it's a whole world of monoclonal antibodies are there. I mean, it's guselkumab. I mean, we don't talk about the guselizumab. I think I told about guselkumab yesterday. Maybe guselizumab can be there, like what Keshav is telling. Guselkumab, no, that has no approval right now. Maybe some part of the world they might be doing a trial, but right now I don't think there is any approval to use guselkumab. But we are using ustekinumab right now, anti IL-12 plus 23 together. So I think that's all. So I think this is how you construct a regimen in SLE. I mean, if you study the textbook, it's going to be extremely difficult to study, like all the drugs, but this will be much useful. So what are the areas which antibodies are tried? Clear? Harshitam is asking something called anifrolumab. I mean, I really don't know. The reason is because why I don't really, don't commit on this kind of monoclonal antibodies, because whatever I know and whatever, I use in practice, only those antibodies I have mentioned, and whatever is commonly used in practice, only those antibodies I have mentioned. And if you take pharmaceutical textbooks, there can be n number of antibodies, and innumerable monoclonal antibodies are there, and it's coming daily. So I don't deny there is no antibody like that, because I can't do that, because it could be still there. I'm not denying that, but I don't know what is anifrolumab. Maybe I've not used it, or I've not heard in any of my guidelines which I've learned till yesterday or the day before yesterday. As far as interferon alpha inhibitors is there, only two drugs I know. One is rontalizumab, and second is sifalimumab. Sifalimumab is there. Definitely it's approved. Rontalizumab is on the way for its approval. It is not yet approved. These are the two IFN alpha inhibitors as far as I know. Rontalizumab is, sifalimumab is available in India also. I've given even a talk on sifalimumab some 1.5 years ago. Fine. So I think, as far as pharmacology is concerned, I think you guys will be knowing better, more than me. These are the drugs I use generally. So SLE proteinuria, can enalapril be given to reduce it? Of course, yes. Why can't you give enalapril in any proteinuria? You're going to give ACE inhibitors. It's not like it's not contraindicated. You can give, no problem. So that's our only additional drug if there is a proteinuria. Clear. I think this will be helpful for you, and this is easy to construct, and it contains all the regimens whatever we have given here. Azathioprine can be used in selected cases of lupus nephritis, but right now, we need not complicate it further. So these are the most important drugs that we're going to use in SLE patients. Clear? What is the most common cause of death in SLE patients? Let us come to some trivia. I told you already. What is the most common cause of death in SLE patients? Yes, cardiovascular death, MI. Cardiovascular death is going to be the most common cause of death in SLE patients. If I ask you what is the most common cause of death in early lupus, if I specifically split and ask, what is the most common cause of death in early lupus? Early lupus is defined as in the first 10 years after the diagnosis of lupus. What is the most common cause? Basically, it should be understood in a different way. Suppose if a patient dies as soon as the SLE diagnosis is made, means the disease itself is so bad. That's why they have died. So the usual reason for death in the first 10 years, it's florid SLE itself. So organ damage, severe organ damage like neurological lupus or lupus nephritis. So that's going to kill the patient. So organ damage, florid lupus, that's the usual cause of death in the first 10 years. Late SLE, after 10 years, which means in the late period, if they want to die, that's where your cardiovascular death comes. So MI is the most common cause. But as a whole, SLE patients usually die of cardiovascular problem only. And apart from that, infections as a cause of death is still there. It's second or third most common cause, but I don't think it should be on the top, because right now our antibiotic regimens are so effective. And of course, one of the reasons why infection-related death is less is because we are abusing antibiotics right now rather than using antibiotics. But it will be only for a short time. If you're going to abuse antibiotics for a long time, this golden era will not continue for long. We are going to suffer a lot in the future. But nevertheless, anyway, that's the reason why currently they don't die of infections. Rather, they are going to die of some form of cardiovascular death or florid SLE itself. And apart from that, what are the relationship with pregnancy and SLE? So as far as predictability is concerned, SLE is one disease that is completely unpredictable. You don't have any risk scoring. That's the most important. We have a lot of activity scoring systems, but there is no model that can predict that SLE is going to go in this direction only. So this is one disease that is completely, and even in pregnancy you cannot predict. And the books will tell you very vaguely that if the patient is having an active SLE, that's a risk factor for development of severe disease in pregnancy. Nirvan is telling pregnancy worsens SLE. There is nothing like that when you go back and read standard textbooks. I mean, I don't know, maybe somebody would have told, maybe would have told pregnancy worsens SLE. It's never like that. SLE is a disease of complete unpredictability. But I can tell, on the other hand, rheumatoid arthritis improves SLE. In the sense, rheumatoid arthritis improves in pregnancy, which means when the patient becomes pregnant, rheumatoid arthritis tend to improve a lot, which means the disease goes into remission usually the moment the patient becomes pregnant, but the disease comes back to the pre-pregnant state within 3 months after the postpartum period. So which means during pregnancy, rheumatoid arthritis is one disease that can have a substantial improvement. But as far as SLE is concerned, you cannot really predict in the first place. In obstetrics, it's given that transition from T helper 1 to T helper 2 pathway in pregnancy, so it flares. So now I'll be asking, what is the role of T helper 2 pathway in SLE? Please let me know. I don't know. What is the role of T helper 2 pathway in SLE? So if there is any role of T helper 2 pathway in SLE, you can let me know, Keshav. I think like the interferon pathway and the dendritic cell pathway are the more important. And that is something where everything starts. So as far as SLE is concerned, I don't think you can really predict that patients will have a good outcome or a bad outcome. The only thing, all rheumatological textbooks like Kelly's Rheumatology, or even if you take some Oxford textbook of rheumatology, the only thing that they mention is before pregnancy, if the disease is severe, we actually advise them not to get pregnant, because that increased disease activity pre-pregnancy is one of the risk factors for getting subsequent flares during pregnancy also. But again, it's a disease of unpredictability. SLE is equal to unpredictability. You cannot really predict that how SLE will behave in pregnancy. It can be silent, or it can be flaring up, or it can become severe, or it can experience organ damage in pregnancy, or it can be completely silent as well. It all depends on the pre-pregnancy state. Pre-pregnancy disease active, there's a substantial risk of becoming getting more flares and getting a worse disease during the pregnancy as well. But there is one antibody that tells you there is increased risk of abortions. That's very important, and everyone knows that is APLA antibodies. Any APLA antibody, if it's there, it indicates a poor outcome as far as the pregnancy is concerned, because you're going to end up with a recurrent abortion. I think that must be enough. That should settle the debate. NP is asking what textbook for final year. I don't know. Many students do ask that, but I studied Kumar and Clark during time, which I liked it. But many of my friends studied Davidson, because during our days we didn't at all have the habit of studying Harrison. I tend to study Kumar and Clark only, basically. That's the only book I studied. I didn't study any other book in my final year. Maybe for clinicals, I studied MacLeod, and for practical exams, there is here and there, I used to take notes from Alagappan. My friends used to take. I didn't study Alagappan basically. Maybe some few points my friends took notes, and I just mugged it up before the clinical exam. That's what I did actually for my clinicals. I studied only MacLeod. MacLeod in and out I studied completely, top to bottom. And Kumar and Clark, yes, fully I have studied. But other books I have not read. Harrison, honestly speaking, I have not read. Even during my post-graduation, I completely stuck to Oxford textbook of medicine. During my time, I studied the 4th edition. Currently, I have the 6th edition. But apart from that, I didn't read any other much books during my post-graduation time also. Oxford is one of my favorite books. It is like a story. So I like kind of a story, kind of a books. So I read that book. That's all. Finally, I read Kumar and Clark. I don't know currently which book is good. Kumar and Clark is very old book. It's a standard book as well. Davidson is also a good book. If you want to study Harrison, if you can study Harrison, that's the question. That's the biggest point. If you can, CAN, that's most important. Then you can study Harrison, no problem. Davidson is also a good book. It's a very standard book. You can study. And I usually used to, get astonished by certain statements. I got one statement last year. One guy texted me in Facebook Messenger, I guess. He told sir, I've studied Harrison 3 times. Is it enough? or I need to study more, or do I need to, like how we should revise and how to go about. I asked which year you are in. He told he's a pre-final year. I again asked, are you a PG or UG? He told UG pre-final year. He studied Harrison 3 times and he's asking me how to revise it. I got a little dizzy because even I have never studied Harrison even one time fully. So I don't know really what to tell. I told I didn't reply. Honestly speaking, I don't know how to reply for that message. And I don't know whether he's making fun of me or whether he have really read it. I'm not joking, but still I got very scared. Like this guy I've really read Harrison 3 times. How is it possible? To read 3 pages of Harrison is you should take it 2 to 3 days. It's such information will be there compressed in 2 to 3 pages of Harrison. It's not that easy to read just 10, 15 pages of Harrison. If you're reading like that 3,000 pages, it's very difficult. It's very depressing. Even as a teacher, it's very depressing to know all this stuff. But still, I don't know whether he told the truth or whether he really did it. That's different. Siddharth asking, what is the best book for PG medicine? Again, Siddharth, if you are able to read Harrison completely, that itself is more than enough as far as the PG is concerned. Nowadays, it's more of a hype that is created in the UG level because this entrance exam have come. That everyone, they told you want to study Harrison, you want to study Harrison. Even if you ask any of the toppers who have studied, they cannot read the entire Harrison. They would have read once probably, but I don't think it's possible to retain everything in the mind, whatever you have studied in Harrison. It's impossible, literally. That too, especially if you're not practicing anything. Harrison is more of a practice book rather than a theoretical book, as far as I know. If you practice and you study Harrison, it will be more easier. But I really don't know how these kids really get Harrison and study, from top to bottom without going into the clinics, without seeing the patients at all. How they're really reading Harrison, I have absolutely no idea. It's very difficult, really, if you don't see patients or if you don't have any sort of practice. It's for practitioners, literally. Even many of my professors are keeping Harrison next to them and they're reading and then they're practicing. So I don't know how a pre-final or final year student is able to complete reading Harrison and they retain Harrison. And maybe either they should be a genius or it should be a bluff. Either way around. It's not possible otherwise, according to me. Or they might be reading very superficially or only important points. I don't know. But it's not possible to have a deeper reading with Harrison. Sanju's telling, I think he confused with Robbins. Even I feel Robbins is one book that cannot be read completely. I mean, because it has a lot of very fine information. You can read the pathophysiology part, but when you take the histopathology part and all, it's too much. You cannot really read. You can take the points, you can mark only the black lines in Robbins and only that named structures, you can tell that Crayola bodies, these are the things, these kind of things you can know, but the minute points is impossible. NEET or next? I don't know whether NEET or next, we have no idea basically. Let us assume because Corona is there and whether NEET will be conducted or not is the big question right now. And we cannot really comment whether NEET or next in this situation. Not possible, according to me. Okay. I think it's time for you to go for a break and come. After that, we have other CTDs and other form of vasculitis, which we're going to discuss. So time, I'm thinking of starting by 7:30, 7:40. But I don't know, my connection should allow that. It's every time it's pissing me off. But come back. Maybe our 7:30, 7:40 must be a right time. Now all combined. Okay, well, I mean, DIAL is there. So I'm going to discuss on drug-induced lupus erythematosus. I'm going to discuss on Apla syndrome. Then we'll be moving on scleroderma. We have Sjogren syndrome. Then we have vasculitis. I think hope we finish today in the next 3 hours. Bye-bye.